Hello, I'm Dr. Simon Petrides, and this lecture is about injections in MSK and sport and exercise medicine. I'm the clinical director at the Blackberry Clinic in Milton Keynes, and the learning objectives today are to understand the variety of injections available, to appreciate the controversy behind some injection techniques, and to appreciate when they may be used, and to ascertain which may be useful for you and how to obtain further training. So the injections that we use can be divided into peripheral injections, which are listed there, and spinal injections. The peripheral ones involve joint injections, soft tissue, trigger point injections, around tendons, into bursae, around ligaments, and into the teno-osseous junctions. Also injections to dilate joints or strip the tenon from tendons with high volume injections. And they also include dextrose prolotherapy and platelet-rich plasma. Spinal injections can be targeted at the facet joints, at the epidural space, at the sacroiliac joint, and also using dextrose prolotherapy. We can also target the trigger points to desensitize them, and also use radiofrequency denervation or neurolysis. They can be guided with fluoroscopy, CT, or ultrasound, and may be done anatomically guided or blind, which is a way some people describe them. Here's just a demonstration of an ultrasound guided injection into the subacromial space, where you can see the subacromial space beginning to dilate with injection just above the supraspinatus tendon. So what might you have in your syringe? There may be nothing. You may be using dry needling or intramuscular stimulation or acupuncture. Anaesthetic alone can be used for myofascial trigger points, using usually a long-acting anaesthetic like bupivacaine, otherwise known as Marcaine. But we can also use anaesthetic alone for diagnostic injections, such as medial branch blocks. We can use local anaesthetic with contrast and saline or steroid for hydrodilation or tendon stripping. The steroid can be used on its own with a depot steroid such as triamcinolone, or a more soluble one such as dexamethasone. Hyaluronic acid can be used, which is a high molecular weight glycosaminoglycans in substances such as ostenil, Synvisc, and so on for lubricating arthritic joints. Dextrose prolotherapy, which is a hypertonic solution of dextrose, or platelet-rich plasma and autologous blood. Lots of options there. So with anaesthetic alone, we may inject it to desensitize trigger points. It can be used to desensitize the capsule of a hip to diagnose hip joint pain. It can be used in the AC joint before a match or a ring block for a small fracture in a toe, just to get the athlete through a match. Medial branch blocks, as in the higher diagram here, showing a needle numbing the posterior branch of the or the medial branch of the posterior primary ramus, which supplies the facet joint with pain sensation. If anaesthetic can numb the pain for a few hours, then that nerve may be amenable to radiofrequency denervation. And ultrasound guided aspiration of joint effusions or bursae and cysts, etc., all just involve anaesthetic. The lower image there is a needle in a Baker's cyst. So how do corticosteroids work? Well, they interrupt the inflammatory cascade, prevent the permeability of the vessels, reduce the migration of white blood cells, macrophages, and reduce the presence of inflammatory mediators, thus calming inflammation, and they are some of the strongest anti-inflammatories known to man. The short-acting ones are hydrocortisone, and the long-acting ones, the depot steroids, which are less soluble, such as triamcinolone, Kenolog, or depomedrone. So why would you want to use steroid injections? Well, inflammatory arthritis, such as rheumatoid, is amenable to injection. So are flare-ups of osteoarthritis, gout, frozen shoulder, any type of enthesopathy. Also myofascial trigger points often have steroid injections or steroid in the injectate. Carpal tunnel syndrome, plantar fasciitis, and so on, ganglions, neuromas, trigger thumbs, and back problems. So the spine problems involve disc protrusions, radiculopathy, facet joint pain and degeneration, sacroiliitis or sacroiliac joint pain, and osteitis pubis, etc. So a lot of conditions are amenable to steroid injections. Now, hyaluronic acid, as mentioned, is a high molecular weight molecule, glycosaminoglycans, and it's found in connective tissue and in the brain, actually, but also in articular cartilage and synovial fluid, and in high concentration in cockscombs of chickens, from where the synthetic hyaluronic acid is manufactured, and it has rheostatic pressure properties. You may wonder what the air hostess is doing in the bottom right-hand corner, but it's only that air hostess is an anagram of rheostasis. So it's also a shock absorber and a lubricant and a metabolic medium or filter. We use it in knee OA or hip joint OA. In the knee, it's been well researched. In the hip, there's less convincing evidence. Some studies show it can be used in other joints, such as the first CMC joint or first MCP joint, or subacromial space or facet joints. There are some controversies due to the ambiguous evidence in some joints. Platelet-rich plasma may last longer in knee OA, but that remains to be seen. Hyaluronic acid is often used with steroid in the first of 3 or 5, up to 5 injections. There is a one-off thicker solution called Ostenil Plus, which can be used, which is just a higher concentration. These may need to be repeated every 6 months. There are often no adverse effects, but there is no actual evidence that there is any regeneration of cartilage after these injections. And it is possible to even use them around tendons, such as in tennis elbow, but with limited evidence. So during the break, this is a slightly shorter first part of this lecture. I'd like you to consider some of these questions about steroid injections. Do they destroy cartilage? Could they cause a rupture of the Achilles or the patella tendon? Do they actually work? Do they have a short-term effect? Are they painful? Are they just a short-term fix? Do you have to keep repeating them? Should they be the last resort, and can they cause osteoporosis, weight gain, and muscle hypertrophy? Could they cause a flare, flushing, menstrual irregularity, skin atrophy, or fat necrosis? Please consider these commonly asked questions to be answered after the break. Thank you.